So we are going to start with the afternoon session, and I'm going to present Aquabeam, our experience. This is my disclosure. And as I told you before in the operating room, this is a machine, a robotic machine. We can treat the prostate with adenoma with a water jet, and it's continuous, controlled by endoscopic vision and transversal ultrasound to personalize the treatment. So, as you can see here, it's a real-time imaging, and for me the most important thing is that it's robotic and it performs the treatment more or less, not today because we have some troubles, but the treatment in established time, and we can perform a personalized treatment with heat-free, which is important to preserve the ejaculation, because in other treatments with the heat, we can damage the ejaculatory ducts. So, as I showed you before, in the surgery, we have the control and we can planify to treat the medial lobe and also to treat the lateral lobes, preserving the bladder neck, the verum montanum, and also the external sphincter. Just a little bit of evidence. The most important studies is Water 1, Water 2 studies. Water 1 is the pivotal study in comparison with TURP for prostates from 30 to 80, and we have 5 years follow-up, and Water 2 is only to treat aquablation prostates from 80 to 150. This is the most important studies nowadays. And this water study allows Aquabeam to stay now in those guidelines, American guidelines, European, NICE, also Canadian and Japanese guidelines. So in the first study, aquablation in comparison with TURP demonstrate that it is not inferior regarding IPSS, urinary flow, post-void residual, and also IPSS quality of life with a good reduction. And when we know nowadays the results of 5 years, we can say that it maintaining across the 5 years with a reduction of IPSS of almost 15 points in both studies, and the retreatment rate in this time is just 6% in Water 1, the majority of them surgeries, but in Water 2, 9% with the majority of them with medical treatment. So across 5 years, so to you before, in maintaining, you have the graphics over there with a good reduction of those things. And also in safety, there is no erectile dysfunction, no urinary incontinence, and the risk of ejaculation was lower with aquablation. That prevent the ejaculation in 93% of patients in this study. In terms of Water 2 study, these processes are bigger. We can see that across 5 years, we have an improvement of 60 points in IPSS, a good reduction of IPSS quality of life, and also a good improvement in the Qmax, still 17. As the same, no erectile dysfunction, and the urinary incontinence in this study with this big process is around 2% only. The preservation of the ejaculation is 85%. Well, this is the first meta-analysis. It includes patients from Water 1, Water 2, and other 2 studies which are smaller, and after 1 year, they subanalyze prostate less than 100 and more than 100 with or without medial lobe. And as you can see here, the continence is quite despreciable. The erectile dysfunction doesn't exist, and ejaculatory dysfunction is only in 10%. So 90% of patients preserve the ejaculation. What's new nowadays is this Japanese study in which they include 103 patients with prostates from 30 to 242. The median is 82 millimeters, and the previous IPSS is 18 plus minus 9. That at 3 months improved to 7 plus minus 5. No important clavien incontinence complications, so these results is more or less similar to those previous studies. And as I told you before, I don't know if you can hear me previously during the surgery. Now there are 2 studies which are doing this surgery in a day case. This is the main study, which includes 60 patients. They treat in the morning, and they perform the aquablation and also the focal bladder neck. And they stayed 4 hours in the recovery with irrigation. And with this, we have a median prostates of 115 And as you can see here, the treatment, the mean operating treatment is 65 minutes. And with this, we can say that 59 of 60 go home the same day with no really important complications. The majority of them is hematuria that is only with a simple bladder wash, and no blood transfusions, no readmissions, no hospitalizations, and no reinterventions. So there is another study which is published in the UK with Neil Barber, and I can show you, like before, that 37 of 40 patients go home without problem with this catheter. They remove the catheter the third day without any problem, and no readmissions and no reoperations, and also no transfusions. What's our experience? Well, we started our program in June of 2021. We have operated more than 150 patients, 3 surgeons at the beginning with Esther García Rojo and now with Fernando Lista. We are the team. And this is the learning curve. This is me with my daughters, and it's me when I started the program. Very excited, but as you can see here, I don't know anything about aquablation. So we have to perform a learning curve. Like the precept says, it's a pathway. You can treat at the beginning 5 patients and till 20, they say, but I think that with 5 or 10 patients, really you feel very comfortable with this technique. As I told you before, is to control the transrectal ultrasound at maximum. So with this man, Tim, he helped me, and I passed from here to believe that I am Aquaman. So 10 cases, this change, and in learning curve there are something published, and all of these studies said that from 10 to 25 cases you can perform, and you can perform the cases, like in this study, 180 in a similar time, independent of the size of the prostate. So with this evolution, I don't know if I'm very brave or very crazy, but we decide to compare our results with this whole rock program. Everyone knows here what our program of Holmium with Javier Romero and also Alfredo Rodríguez Antolín and Borja García Gómez. We have performed more than 4,500 cases with 3 expert surgeons and a lot of publications. So we decided to, there is nothing in the literature in comparison Aquabeam versus Holmium. We are waiting for the Water 3 study, and we have sent this study to Minerva, and we are crossing fingers. I think that in a few days or months, maybe we have this paper. So we decided to design a prospective multi-center comparison between these techniques. We include 75 patients in each branch. Holmium is performed by the surgeons, and aquablation by Esther and me at the beginning with a standard technique. We include patients with moderate to severe BPH symptoms, with no previous surgery, no previous urethral stricture, bladder tumor, or lithiasis, and no prostate larger than 120, because we include in this study those patients of the learning curve, so we don't want to be more optimistic. So as you can see, the preparative variables, there are no differences between both populations, with a prostate volume of 81 in Holmium group and 71 in aquablation, Qmax around 9 points, and IPSS around 23 or 20 points. In the intraoperative variables, we find differences between the treatment time, treatment that the water is treating the prostate in aquablation and the enucleation in Holmium, but we don't find differences in surgical time. It has 2 explanations for me, that we include the first cases, and that Javier Romero is really quickly, because as you can see here, to enucleate a prostate, I don't have it, to enucleate a prostate in 22 minutes of 81 cc's is not the typical thing. So maybe if we can change this date for the majority of the surgeons, we can find surgical time differences. But that's our results. In postoperative variables, the main difference is the hemoglobin loss, more in aquablation group, but it doesn't mean that we have to transfuse more patients to reoperate any patient in both groups. And the time to discharge, catheter time, and emergency visit transmission or recatheterization is the same in both groups, no differences. And the functional and follow-up variables at 6 months, you can see that we have found three differences. The volume of the prostate and the tissue resected is bigger in Holmium group, but it doesn't mean that we have differences in terms of Qmax or the reduction of IPSS, around 15 points in both groups. And no difference in incontinence, and also the main difference is the ejaculatory dysfunction, which is preserved in around 96% of the patients of aquablation. After 150 patients, those are my conclusions. I think that it's not only the preservation of the ejaculation. The main thing that everybody says of this treatment is that you can preserve the ejaculation, but this really works. Not today. Today I have a little problem in the operating room. For this reason, I take so much time, but it works, and I think that it's important to say that it has a good development over this treatment, because a month before, Procet has presented the Hydros, which is the new machine which uses artificial intelligence and is changing a lot. We have really good results in symptom relief, allows to treat the majority of the prostates, so we have no limitations in this way. With established surgical times, all or the majority of our patients, not all, but the majority have a high satisfaction. It has a short learning curve, and I think that it's very simple to start it, apart from the price, obviously. But you don't need really mentorization like in other techniques. And it's changing a lot the hemostasia. We know that the Achilles heel of this treatment is the hemostasia, but nowadays, with changing, I always say that all treatments in surgery have to develop, to go step by step, and nowadays it's changing a lot this way. We need to comparative study, obviously, with the gold standard in more longer follow-up time, and we need, obviously, also cost studies. And just to finish, if the evolution is this after 10 cases, so I think that to be like this, I have to do something else than aquablation, maybe go to the gym, I don't know. And thank you very much for your attention.